Welcome to All in All.
Hey there.
Today, we're doing a deep dive specifically for, well, for you, the dialysis RNs and techs out there. Maybe you're getting ready to step into that dialysis nursing role.
Exactly. Our mission today is really to take those essential lab markers, the ones you see constantly, day in, day out in the clinic,
Right.
and really unpack what they mean clinically. We want you to get past just seeing a number, understand the story it's telling about your patient, about the care you're providing.
Yeah, moving beyond the digits, we'll start with the real foundations and build up to some deeper clinical insights. The idea is to help you see these labs as like key pieces of the clinical puzzle.
Hopefully giving you a clearer picture of your patient's condition, making you feel, well, more confident and prepared in your role.
Definitely. Okay, let's get into it. So let's start with those big three you see all the time, BUN, creatinine, and GFR. What are we actually looking at with these?
Okay, so think of BUN and creatinine as like the main waste products, stuff the kidneys are supposed to clear out. They're byproducts from metabolism. BUN, this blood urea nitrogen, comes from the protein we eat.
Ah, so that means BUN can kind of bounce around a bit. It's not just kidney function affecting it.
Exactly right, yeah. Kidney function is the main thing, sure, but BUN can also creep up if someone's dehydrated, or maybe they have heart failure, even if their kidneys aren't, severely damaged yet.
Gotcha. What's the typical range we're looking at?
Usually the normal range is cited somewhere around 7 to 20 milli-GDL. Gosh.
Okay. And creatinine? How's that different?
Creatinine comes from muscle metabolism, muscle breakdown.
Right.
And because it's less affected by things like diet or how hydrated someone is compared to BUN anyway,
Right.
it's generally seen as a more, reliable indicator of actual kidney function.
Makes sense. And the ranges differ a bit.
Yeah, slightly for men and women due to average muscle mass. Maybe 0.6 to 1.3 milli-GGL for males, 0.5 to 1.1 for females, roughly.
So bottom line, when these numbers, BUN and creatinine, are high, it's a pretty direct sign the kidneys just aren't filtering waste out effectively.
Precisely. And, when kidney function is already pretty low, even small changes in creatinine can mean a really significant shift in their remaining function. It's not always intuitive.
Interesting. So you got to watch those trends closely.
Absolutely. It gives you a clearer picture of how things are progressing or maybe even declining.
Okay, and that brings us to GFR, the glomerular filtration rate.
Yeah, GFR. This is generally considered the best overall estimate we have of kidney function. It's not measured directly, it's calculated.
Calculated using what?
Uses that serum creatinine level, but it also factors in age and gender because, again, muscle mass varies.
And GFR is how we actually stage chronic kidney disease, right?
That's the standard, yes.
Yeah.
It goes from G1, which is a GFR over 90, though there has to be other evidence of kidney damage for it to count as CKD.
Like protein in the urine or something.
Exactly. All the way down to G5, which is defined as a GFR under 15, or the patient is already on dialysis.
Can you quickly run through those stages?
Sure. G2 is 60-89, G3A is 25-59, G3B is 30-44, G4 is 15-29, and then G5 is below 15. It just helps classify the severity.
Now, importantly, hitting a GFR of, say, 14 doesn't automatically mean dialysis starts tomorrow, does it?
Oh, absolutely not, no.
Yeah.
While that GFR range may be below 20, certainly below 15, is where dialysis often becomes necessary. The decision to actually start dialysis, it leans really heavily on the patient's symptoms, their clinical status.
Not just a number on the page.
Not just the number. It's about how the patient is doing.
Okay. So for you, working in the clinic, these BUN, creatinine, GFR numbers are absolutely fundamental. They're like the kidney's progress report.
Yeah, they give you that immediate snapshot of how impaired the kidneys are, what stage of CKD the patient is in. It's your starting point. And understanding that level of impairment, that leads us right into the concept of uremia.
Uremia. Okay, so that's when the waste products really build up to toxic levels.
Essentially, yes. The body is being poisoned by all the things the kidneys can no longer clear out. And it's not just urea, it's a whole cocktail of biochemicals.
And that buildup is what causes all those symptoms we see.
Exactly. It causes this incredibly wide range of symptoms, things you'll definitely encounter, like nausea, vomiting, that crushing fatigue that patients talk about.
Yeah, the fatigue seems huge.
It is. Loss of appetite, which affects nutrition, those awful muscle cramps, sometimes during treatment, sometimes after, and the itching. Pruritus can be maddening for patients.
I've definitely seen patients who seem confused or have bad headaches. Is that related?
Oh, absolutely.
Oh.
Altered mental status, headaches.
Ah.
Sometimes you might even see asterixis, that flapping hand tremor.
Right, the flap.
In really severe, maybe untreated cases, you might even see things like uremic frost on the skin or notice uremic fetor, a kind of distinct smell on their breath.
Wow.
And critically, you see the effects of fluid buildup, swelling, edema, fluid in the lungs, pulmonary edema, and really high blood pressure, because that extra volume is a major driver of hypertension in end-stage renal disease.
And in really bad cases.
It can even affect the heart lining pericarditis or cause serious brain dysfunction, uremic encephalopathy.
That's a really stark picture, and recognizing these symptoms is so vital because, like you said, symptomatic uremia is often the trigger to start dialysis, more so than just the GFR numbers sometimes.
Precisely. If someone comes in with, say, potassium that's dangerously high and won't come down, or severe metabolic acidosis, or that uremic encephalopathy, dialysis is often needed urgently.
So, as a nurse or tech, connecting those lab numbers, we talked about the BUN, the creatinine, to what you're actually seeing in the patient, their symptoms, that's crucial for spotting these urgent situations.
Couldn't have said it better. That connection is key.
Okay, so beyond waste, kidneys also manage electrolytes and minerals. Let's talk about potassium, phosphorus, calcium, and PTH.
Right. These are hugely important. Potassium K plus A is essential for nerves and muscles to work properly, including the heart muscle.
And the kidneys normally keep that in check.
They're the primary regulators. So when they fail, getting rid of potassium becomes difficult.
Leading to high potassium hyperkalemia, that sounds serious.
It is. It's very common in CKD because excretion is impaired. And certain things can make it worse, like some blood pressure meds, ACE inhibitors, ARBs.
Like lisinopril or losartan.
Exactly those. Diabetes, heart failure, even diet, like using those salt substitutes that are high in potassium.
And why is high potassium so dangerous?
The biggest risk is cardiac arrhythmias, dangerous heart rhythms. Severe hyperkalemia is a true medical emergency and often requires immediate dialysis. Long term, we use things like potassium binders to help manage it.
What about the flip side? Low potassium hypokalemia, is that common too?
Less common in advanced kidney failure, but yeah, it can happen. Maybe from GI losses like vomiting or diarrhea, or sometimes from certain diuretics used earlier on.
Still dangerous, though?
Oh, yes. Severe hypokalemia can also cause dangerous heart rhythms. It needs prompt treatment, sometimes IV potassium, definitely with cardiac monitoring.
Okay. Now, phosphorus. We hear about phosphate binders constantly. Why is phosphorus such a big deal?
Well, just like potassium, healthy kidneys get rid of excess phosphorus. When they fail, phosphorus levels build up in the blood that's hyperphosphatemia.
And high phosphorus isn't just a number, right? It causes other problems.
Big problems. It throws off the balance with calcium, which then signals the parathyroid glands to pump out more parathyroid hormone, or PTH.
Right.
This whole cascade contributes significantly to bone disease, renal osteodystrophy. Makes bones weak, painful. And maybe even worse, it promotes calcification. Calcium phosphate deposits in blood vessels, soft tissues.
Not good. So managing phosphorus is crucial, hence the binders.
Exactly. Phosphate binders work in the gut. They grab onto the phosphorus from food, preventing it from getting absorbed into the bloodstream.
And the timing is key.
Absolutely critical. They have to be taken with meals or snacks to work. If you take them on an empty stomach, they don't do much good. This is a massive nursing education point, helping patients understand the when and the why.
Makes sense. And how do calcium and PTH fit into this picture more broadly?
So failing kidneys also struggle to activate vitamin D. You need active vitamin D to absorb calcium from your food.
So calcium levels can drop, hypercalcemia.
Can happen, yes. And that combination, low calcium and high phosphorus, is a major stimulus for the parathyroid glands to release PTH. So you often see very high PTH levels in dialysis patients. Monitoring all three, calcium, phosphorus, PTH, helps guide treatment to manage that bone disease.
So for the nurses and techs listening, keeping track of these electrolyte and mineral levels is obviously vital, but it's also about the education piece.
Huge. Reinforcing dietary advice, making sure patients really get why they need their binders and when to take them, and little things like reminding them to avoid magnesium-containing laxatives or antacids, because magnesium can also build up to dangerous levels.
Good point, like milk of magnesia. Avoid that.
Definitely avoid that. Okay, another really common, almost universal complication in CKD is anemia.
We're at the anemia of CKD. Why is it so prevalent? Why do so many kidney patients become anemic?
Well, the main reason is that the kidneys aren't producing enough erythropoietin. That's the hormone, EPO, that signals the bone marrow to make red blood cells.
So less signal, fewer red cells.
Pretty much. Plus, the chronic inflammation that often comes with CKD messes with how the body uses iron, and it can also shorten the lifespan of the red blood cells that are made. It's kind of a triple whammy.
And you really see the impact of this anemia on your patients, don't you?
Oh, absolutely. It's often one of the most debilitating symptoms. Patients describe this profound fatigue, just feeling wiped out all the time, no matter how much they rest.
Feeling cold, maybe? Dizzy?
Yes, feeling cold, dizziness, shortness of breath, even with just a little activity, it really impacts their quality of life significantly.
So what specific labs are we tracking for anemia?
The main one is hemoglobin, HGB. That tells us about the oxygen carrying capacity. But we also need to look at iron status.
Iron studies, like ferritin.
Right. Ferritin gives us an idea of iron stores,
Yeah.
but we also look closely at transferrin saturation, or TSAT.
Okay, explain TSAT. What does that tell us specifically?
TSAT is really important.
Yeah.
It tells you how much iron is actually available in the bloodstream, ready to be used by the bone marrow to make those red blood cells. Think of it as usable iron. We usually aim for a TSAT over 20% in dialysis patients.
So it gives a better picture than just storage levels alone.
Exactly. You need both ferritin and TSAT for the full picture.
And the treatment typically involves replacing that missing hormone signal and giving it iron.
That's the core strategy.
Yeah.
We use medications called erythropoiesis-stimulating agents. ESAs, you'll see names like epoetin alpha, darbepoetin alpha. They mimic the natural EPO.
And iron?
And iron supplementation is crucial. Often it's given intravenously during the dialysis treatment because oral iron isn't always well absorbed or tolerated. We need to make sure the bone marrow has the building blocks it needs when the ESA stimulates it.
Are there other options? I think I heard about one that also helps with phosphorus.
Yeah, there are some interesting newer oral agents. Ferric citrate is when it's an oral iron that also happens to bind phosphate in the gut. So kind of a 2-for-1 benefit for some patients.
So for the dialysis nurse or tech, your role here is monitoring those HGB and iron labs, giving the ESAs and IV iron as ordered, but also really assessing how the patient is feeling.
Absolutely. Asking about that fatigue, the shortness of breath, recognizing how much it impacts their daily life. That clinical assessment is just as important as the lab number.
Okay, let's shift gears just a bit. Let's talk about proteinuria, or sometimes you'll hear albuminuria.
Protein in the urine, is that always a bad sign?
Yeah, significant amounts, yeah. Especially albumin, which is the main protein we look for. Healthy kidneys have filters that keep most protein in the blood. So when it starts spilling into the urine, it indicates damage to those filters.
How do we measure it accurately? The standard test now is the urine albumin to creatinine ratio, the ACR. Usually done on an early morning urine sample, which is typically more concentrated. A simple urine dipstick can screen for protein, but it mainly picks up albumin and isn't as precise as the ACR.
And why is this ACR value so important in managing kidney disease?
Because it's not just a marker of current damage. It's actually a really powerful predictor of how likely the CKD is to progress.
So higher levels mean higher risk of worsening kidney function.
Exactly. We graded A1, A2, A3 based on the amount. The higher the grade, the higher the risk of decline, independent of the GFR level, actually.
And lowering that protein level is a treatment goal, right?
Yeah.
Often using blood pressure meds.
Yes. Reducing proteinuria is a key target to try and slow down the progression of CKD. Certain classes of blood pressure medications are particularly good at this. Okay, now let's really connect these lab values to the super practical day-to-day stuff. Fluid status and vascular access.
Yes, fluid management. This feels like the absolute core of daily dialysis care. BUN and CR tell you about waste, sure, but that fluid status, it determines so much about how the patient feels moment to moment.
Absolutely paramount. Because their kidneys aren't making urine, or very little, patients gain fluid weight between treatments. This fluid overload, hypervolemia, is everywhere. You see it as swelling, edema.
Shortness of breath?
Definitely.
Yeah.
Makes it hard to breathe. Fluid backs up into the lungs.
Yeah.
And like we said, it's the #1 cause of high blood pressure in ESRD patients.
Yeah.
So you're constantly monitoring their weight gain between sessions, the IDWG, their blood pressure, before, during, and after treatment, listening to their lungs.
And the goal of dialysis is to remove that excess fluid, the ultrafiltration, but taking too much off or too fast causes problems too.
Right, the opposite issue, hypovolemia. Removing too much fluid can cause their blood pressure to drop during treatment hypotension. They might feel dizzy, get cramps, feel nauseous, even pass out.
Which is exactly why checking that blood pressure so frequently during the dialysis run is non-negotiable. It's a safety essential.
Totally essential.
Yeah.
And adjusting the rate of fluid removal, the UF rate, based on how the patient is tolerating it, their BP, their symptoms. That's a constant nursing judgment call, usually guided by physician orders, of course.
You're always watching their weight, their pressures, how they look, how they say they feel.
Constantly assessing. It's a balancing act.
And intricately linked to all this is the patient's vascular access. their lifeline, really.
Couldn't do dialysis without it. Whether it's an AV fistula, an AV graft, or a central venous catheter, keeping that access working well is absolutely key.
And assessment is critical.
Your hands-on assessment skills are vital here. For a fistula or graft, that means feeling for the vibration, the thrill, and listening with your stethoscope for the whooshing sound, the bruit, every single shift, before every needle stick.
And being vigilant for complications?
Yes. Looking for signs of infection, redness, warmth, drainage, watching for clotting, where the access stops flowing, or sometimes Steele syndrome, where the fistula steals too much blood flow from the hand, causing pain, numbness, coldness.
And simple safety things are huge, too.
Huge. Like always making sure those little clamps are secured to the dressing over an AV shunt site. If that access gets accidentally pulled out, the bleeding can be catastrophic. And basic rules like never using the access arm for blood pressure checks or routine blood draws, protecting that lifeline. Okay, lastly, let's just briefly touch on how understanding all these labs helps you recognize and react to acute complications, things that can happen suddenly.
Right, because the labs give you the background context for why something might be happening, like disequilibrium syndrome.
Yeah, this can sometimes happen, especially when patients are first starting dialysis and their BUN levels are sky high. When dialysis pulls urea out of the blood really fast.
It's faster than it leaves the brain cells.
Exactly. It creates this temporary osmotic gradient pulling water into the brain cells. Symptoms can range from just a headache or nausea to real confusion, muscle twitching, and in rare, severe cases, even seizures. Knowing their pre-dialysis BUN helps you anticipate this risk.
Okay. And for patients on peritoneal dialysis, PD, the big risk is peritonitis.
A major concern. It's an infection inside the abdominal cavity, the peritoneum. The absolute key signs you look for are cloudy dialysate fluid coming out, abdominal pain, and maybe a fever.
And the response needs to be quick.
Immediate. Get a sample of that cloudy fluid for culture right away, notify the doctor. And prevention is all about meticulous aseptic technique during exchanges and changing any wet or soiled dressings promptly.
And one more critical emergency, this one in hemodialysis, air embolism.
Yes. This is rare, but absolutely terrifying and life-threatening. If a significant amount of air gets into the bloodstream,
what would you see?
Sudden shortness of breath, maybe chest pain, the patient might look pale, be very anxious, their heart rate might shoot up. It's an emergency.
And the immediate action is?
Clamp the lines. Clamp the blood lines immediately to prevent any more air getting in. Stop the dialysis machine. Get help. Notify the physician right away. Position the patient appropriately if possible. Every second counts.
So you can really see how it all ties together. The lab numbers aren't just data points. They're dynamic. You have to combine them with your vital sign monitoring, your physical assessment, listening to the patient.
That's how you get the full story. That's how you anticipate problems and know how to respond effectively when things go wrong. It's about integrating everything.
Okay, so let's recap. We've covered quite a bit. Those essential lab markers you'll see daily, BUN, creatinine, GFR, giving you that window into kidney function, CKD stage.
We dove into electrolytes and minerals, potassium, phosphorus, calcium, PTH, and how imbalances affect the heart, bones, the whole body, really.
Right. We looked at hemoglobin, iron, TSAT to understand anemia, which is so common, and how it's managed with ESAs and iron.
We touched on proteinuria, that ACR value, as a key sign of kidney damage, and importantly, a predictor of progression.
And then we really tried to connect those labs to the practicalities. Managing fluid balance, which is just so central to dialysis care.
And understanding how those labs influence the care and assessment of the patient's vital vascular access.
And finally, how knowing these labs helps you recognize and respond to those acute, sometimes scary complications like disequilibrium, peritonitis, or an air embolism.
It all relies on putting the pieces together, the labs, the assessment, the patient's story.
So for you, whether you're a seasoned tech or maybe just starting out as a dialysis RN, really getting a handle on these numbers, it truly empowers you.
It absolutely does. It lets you provide more informed care, more proactive care. You can anticipate issues sometimes, communicate more effectively with the doctors, the dietitians, the whole team.
And ultimately, it helps you contribute to better outcomes, better quality of life for the people you're caring for, which is the goal, right?
That's the goal. These markers, they're like the language the kidneys use to tell you what's going on. Learning that language helps you translate it into meaningful action at the bedside.
So let's leave you with a thought to mull over. We talked about how uremia causes a huge range of symptoms and how starting dialysis often hinges more on those symptoms than just a specific GFR number. So thinking about that, What specific combination of uremic symptoms, maybe coupled with trends in those basic labs like BUN and creatinine, do you think are the most urgent clinical red flags? The signs that tell you at the bedside, this patient really needs dialysis, like now. Why that particular combination?
Yeah, what does that picture look like in your clinical judgment? Something to definitely consider as you continue learning in this really vital field.
Absolutely. Thanks for listening to All in All.